As we started to evaluate her, we discovered that she has not just the chronic rejection of the lung, but her liver was failing from her cystic fibrosis, and her kidneys were also failing. So not only did she need a second time lung transplant in a condition that is generally considered to be a contraindication for transplant, but she needed a liver and a kidney. And that has never been done to the best of our knowledge in the world. Unfortunately, Elizabeth had predominant RAS features of a chronic rejection, which by itself is not considered often for a redo lung transplant. The redo lung transplant is perhaps the most challenging part of this, because a double lung transplant itself is generally considered to be one of the most complex surgical procedures that we perform in the hospital. But now you're talking about a retransplant in the context of a rare form of chronic rejection. During that process, we were able to use some novel machines to keep the liver alive outside as we were putting the new lungs in. But because we had done a lot of that dissection up front, the new lungs didn't take that long. And as a result, the liver didn't have to stay that long outside the human body.
They were on a machine perfusion pump. And this is fantastic because we can allow the lung team to take their time and do what they need to do to make sure that the lungs go in safely without being on the clock, per se, for the abdominal organs. And then when the abdominal organs go in and blood gets back to them, they begin to function straight away. In the operating room, a highly coordinated group of both thoracic and abdominal surgeons working together in constant communication with our anesthesiologists and nursing teams to make sure that we are delivering high quality, better care.
And our abdominal transplant team were able to quickly put the liver in, and then soon after we were able to get to the kidney. So that whole operation had to be very closely choreographed with so many different team members and two different teams, our team and the abdominal team, working in extremely close collaboration to make sure there's no single misstep. We put in, there were upwards of 20 hours of total surgery time, but by separating it out this way, we were able to get the outcome that we hoped we would for her. We have a really, I would say, a passionate team that is always thinking about bringing in novel solutions to our patients. She did exceptionally well within a couple of weeks after the multi-organ transplant. Her lungs were working great, liver, kidney, and she was able to get discharged within a couple of weeks.
It's important to be self-aware, to offer the best care for patients. And so I think it's a kudos to the institution that felt that this patient needs to have care given to them in a particular way. There's very few places, I truly feel, that have the resources, but also the collaborative efforts that we have at Northwestern. I think that having the collaborative teams, that communication, it just becomes seamless, and it translates to better care for patients.